In this video, we describe the thoracic wall, how to remove it, and how to remove the heart and lungs from the thorax. This work was created by Dr. Carlos Andres Suarez-Quian and Dr. Joel Walensky. Dr. Suarez-Quian is the narrator of this video. If you have ever wondered why boots on the ground wear body armor, indeed, why if you visit any medieval museum you're likely to see rows upon rows of complete suits of armor, the answer is here. Hearts and lungs, two of the vital organs for life. The heart drives the cardiovascular system. The lungs allow us to breathe. They are the business end of the respiratory system. Let's start the dissection of the thorax. We begin by removing the thoracic wall, lungs, and the heart. In this body, the pectoralis muscles, major and minor, were reflected earlier, as was the serratus anterior muscle. However, the intercostal muscles are all intact. If we look at the intercostal muscles more closely now, we notice that they're in layers. The external intercostal muscles extend obliquely downwards. Their orientation is similar to that as when you put your hands into your pant pockets. In contrast, the internal intercostals run perpendicular to the external intercostal muscles. Realize, however, that the external intercostal muscles do not extend to the sternum, except as a membranous layer, which had to be removed in this specimen to demonstrate the internal intercostal muscles. Likewise, the internal intercostal muscles end approximately where the external intercostals begin, but they too connect to the membranous layer that continues to the vertebral column. Also, deep to the internal intercostal muscle is another layer of muscles not shown in the image, the innermost intercostal muscles. We will see the innermost layer of muscles when we reflect the thoracic rib cage. Of note, the intercostal vein, artery, nerve run between the internal and innermost layer of muscles just below the inferior border of the corresponding ribs. Next, using a scalpel, the intercostal muscles are removed to continue with the dissection. In this different cadaver, the intercostal muscles have been removed to reveal the left and right internal thoracic vessels, which supply the chest wall, including the breast. Some cardiovascular surgeons transplant these arteries to the heart to supply the blood when a patient's coronary arteries are occluded. The intercostal vessels must be freed of adhesions, as shown here, so that they are not removed with the chest wall, although often one side is indeed left attached to the chest wall and thus removed with it. The lungs and their coverings, the parietal pleura, are visible through the intercostal spaces. Because the clavicle is attached to the sternum, it must be cut to remove the chest wall. Here, the right clavicle is being cut with a bone saw. We then use rib cutters to cut each rib as far posteriorly as possible to gain maximum access to the thoracic cavity. Here, the left ribs are being cut. And in this slide, we see the same process being done on the right side. The hand is then placed under the rib cage and gentle pressure is applied to raise the rib cage. This pressure results in the rib cage rotating upwards, using some remaining soft tissue as a hinge. Here we see the fully elevated rib cage. The fibrous pericardium containing the heart is visible, as are the lungs within the parietal pleura. To begin the process of lung removal, we must remove the parietal pleura to reveal the lungs. Here we see the parietal pleura on the left is being gently lifted off the lung. With much of the parietal pleura removed, the upper lobe of the left lung is revealed. The lower lobe is located more posteriorly in the cage and is not visible in this view. Removal of the lung begins by retracting the lungs laterally to expose the hilum of the lung as shown on the image. The hilum is the location at which vessels and nerves enter and leave the lung. To remove the lung from the thoracic cavity, we must transect all structures entering the lung at the hilum, as shown here in this magnified image. Once the hilum is cut, we gently pull the lung out of the thorax. The right lung is removed in the identical manner to that on the left, and in this image, we see the thoracic cavity after removal of both lungs. Note the cut edge of the parietal pleura on the left lung that are labeled and compare them with the ones on the right lung. Also apparent in this image now is the right hemidiaphragm, which is elevated compared to the left hemidiaphragm by the underlying liver. Removal of the lungs leaves the entire mediastinum intact. This is the middle region of the thorax. The most prominent component of the mediastinum that is now visible is the heart, covered by its fibrous pericardium. To begin the removal of the heart, we incise the fibrous pericardium to enter the pericardial cavity. Once the pericardial cavity is open, we can see the heart itself, shown in the slide. Note the abundance of fat, a common feature in many hearts. And now we can discern specific structures, such as the pulmonary trunk, the ascending aorta, the right atrium, and the superior vena cava, and finally, the coronary sulcus separating the right atrium from the right ventricle. The goal now is to instill a finger in between the ascending aorta and the right atrium and the superior vena cava. This is the transverse sinus. Here, a probe has been instilled in the same space as had the finger, and now almost all of the anterior features of the heart are visible. As shown in the image, the left and right ventricles are separated externally by the interventricular sulcus. Also visible are the superior and inferior vena cava as they enter the right atrium. We cannot see the left atrium in this view because it is located more posteriorly. In order to remove the heart, it is necessary to transect both the ascending aorta and pulmonary trunk. Similarly, we need to cut the superior and inferior vena cava where they enter the right atrium. The last structures that are keeping the heart still attached are the 4 pulmonary veins that need to be cut now. After raising the heart gently, we see the 2 lower pulmonary veins, which we will cut using a scalpel. However, we have also entered the space known as the oblique sinus, which can be of significant clinical relevance. The oblique and transverse sinuses do not communicate. Hence, fluid, especially blood, that collects in the oblique sinus, for example, following a massive heart attack, has no way of escaping and will continue to accumulate in the pericardial cavity. This condition is known as cardiac tamponade and will be characterized by veins becoming engorged in the neck. If the patients are not taken immediately to the operating room to repair the hole in the heart, the patient will die because the pressure outside the heart due to the blood fluid buildup will be too high for the heart to pump against. Continuing with the dissection, we continue racing the heart, identify the 2 remaining pulmonary veins, then cut them. The heart is then gently pulled forward and any remaining adhesions are cut. And finally, we here show the removed intact heart with many of the same structures apparent as when the heart was still located in the thoracic cavity. Additionally, in the removed heart, we can now clearly see the heart's apex, which is where the left and inferior borders of the heart join, and which is the part of the left ventricle. This now concludes the first dissection of the thorax.